So can you see my slides?
Yes, sir, we can see.
Right. Thank you. Right, I'm just trying. Okay. So this is the MCGP batch, right?
Yes, sir.
Okay. So mm, so I'm Professor Chandima. So I'm Professor in Allergy at the University of Jagadhanapura. So I was asked to talk you through some allergy topics for the primary care physicians. So I thought I'll do a series of 2 to 3 lectures from the experience I have with multiple referrals I received from the general practitioners or family physicians. So let's, before getting into the lecture, let's find out why is it important, allergy as a topic for a general practitioner. So it is estimated that about 20 to 30% of the population is affected by allergy. Although we don't have the exact figures for Sri Lanka, this is the common accepted norm for allergic prevalence. And most importantly, majority of these can be managed in primary care, but you need to be proactive in managing them. And again, the children are widely affected, especially with our modern Western practices. Also, the hospital admissions for allergies has increased at least tenfold over the past 10 years. Unfortunately, most of these patients remain undiagnosed in our part of the world because we don't have allergy specialists, allergy trained specialists in Sri Lanka. And apart from that, most of our medical officers, general practitioners has had only a limited amount of training in their undergraduate curriculum and most of their postgraduate curriculums. They have not exposed to proper allergy training. And the current practice for a patient with allergies are to refer to a dermatologist most often, and sometimes to a physician or a pediatrician. But unfortunately, none of these specialists have had formal training in allergy. So that's why most of these allergy patients are not properly managed, even at secondary and tertiary care. So what are the effects for the patients? So in terms of children, there are quite a lot of sleep disruptions. I'll go through different clinical scenarios and how I will explain how these allergic diseases can affect the sleep and the education and growth. And still we see in Sri Lanka at least 40 to 60 fatal anaphylaxis cases per year, which is quite unfortunate because all these are preventable deaths. So if we talk about the levels of care in allergy, mostly in Sri Lanka, patients still prefer self-care. Whenever they encounter allergic reaction, the first thing they would do is go and take a tablet of chlorpheniramine, commonly known as Piriton. And sometimes they go to the nearest pharmacy and they get a prescription, uh, the pharmacist will dispense some medicines. Mostly it could be Piriton, cetirizine, sometimes it could be Phenergan, along with the steroid. Then in about another proportion of patients would walk to you or seek your help in managing the allergies. What you guys would do is you do a basic allergy management, mostly symptomatic. And then if you can't manage, you seems to refer this patient to a specialist. And usually the specialists are either a dermatologist, in most of the cases you refer to a dermatologist. Sometimes you might refer to a physician, because I have seen patients being referred to physicians, pediatricians, and also some of these patients will go directly into the emergency room, and they are managed by the emergency physician. So most of these patients will end up here, um, rather than going for proper allergy evaluation. So for example, so this is one of the common practices. You can see this patient මේ පොල් කොළ දාලා පොල් කොළ වලින් දුම් වලින් තමයි ඇලර්ජි එක හදනයා කරගන්නේ. So this is one of the ancient practices in Sri Lanka. So and still people I know I have seen patients who still continue to practice this as a method of getting a cure from allergies. So most importantly, we do have a tertiary care services for complex allergy management. For example, our university, we do have the Institute of Allergology and Immunology, where we offer a full range of allergy investigations, management, and even immunotherapy. So that's very important for you guys as primary care physician to understand. If you can't manage, it's very important get the proper specialist, get into the proper specialist pathway and get the patient sorted out. Otherwise, the patients will be at the receiving end without getting proper care. So whenever you encounter a patient with allergic symptoms, sometimes there could be vague symptoms also. So what you need to understand is whether it's allergy or not. For example, a patient, you might see a patient with sudden onset difficulty in breathing. So if you think of differential diagnosis, it could be a case of bronchial asthma exacerbation, or it could be an acute allergic reaction. So as the primary care physician, the first contact person, you need to quickly make a decision whether this is an allergic reaction or not. If it is an allergy, then you need to decide whether it's life-threatening or not. If it is life-threatening, the management is different because you need to give IUM adrenaline. But if it is not, you can manage them with antihistamines and plus or minus with steroids. But as a general practitioner, what you see would be a range of patients with acute urticarias, acute allergic reactions, or patients who would be coming to you repeatedly over a period of weeks to months for the same illness. So they might attribute their symptoms for different types of food. But unfortunately, there is no consistency. For example, a patient might say, Doctor, I developed an allergic reaction when I eat chicken. So I stopped eating chicken. But I went to a wedding, but on that particular day, I felt like eating chicken. I ate chicken, but I didn't get a reaction. And then again, then I started eating chicken, and after about 2, 3 occurrences, again I started developing a reaction to chicken. So there is no consistency with the food intake. So it's patients are quite fond of associating their allergy reactions to foods, although especially in chronic urticarias, there is no relationship with the food and the onset of symptoms, but they like to associate with certain protein products, protein foods. And also doctors are encouraging that practice. So that's very important to understand. Always, all allergies are not due to foods. Right. So I was talking about with, when you encounter a patient with allergic symptoms, you need to decide whether it's life-threatening or not, because if it is life-threatening, the patient needs IM adrenaline. And the most important question that we need to answer is, what causes these symptoms? How do we prevent? And what is the long-term management? So those are the questions that you need to answer as a primary care physician or the first contact doctor who will be treating majority of these patients. I would say 98% of the time, these patients are seen by you, not by us. So it's very important that you give correct advice guidance to these patients to get over their symptoms. So as GPs, when you see a patient with an acute allergic reaction, you would treat immediately. And some of you would treat and finish it. And some of you would decide, okay, I will treat the acute episode, but I would like to know what triggers this reaction. And they would investigate a bit further. And then some of you will review this patient and look at these test reports and would decide, okay, now this is beyond my expertise. I would need some specialist advice, and you will decide to refer to a specialist. An ideal situation is you need to refer to this patient to an allergy specialist for further investigation and management. And on the other hand, if it is an acute life-threatening reaction, you would do the immediate management and would definitely admit this patient. So these are the four things that you would be doing as a primary care physician or the primary care first contact doctor. So it's important to triage your patient to which category that you are initiating your treatment plan. So let's talk about a bit of immunology on acute allergic reaction. So acute urticaria is a type 1 hypersensitivity reaction, and it's called the immediate type because it says usually the reaction occurs within 1 hour. It could be a drug, or it could be a food, or anything, or environmental trigger. So when we say IgE mediated reaction, it's for a acute urticaria, IgE mediated acute allergic reaction, you should at least need 2 exposures for a person to develop a true allergy. Because on the very first exposure, the body recognizes the allergen, and then they will produce IgE antibodies. And these IgE antibodies goes and gets attached to the mast cell. This is the mast cell. The mast cell is the main mediator of allergic reactions. So that's why for any IgE mediated reaction, you need the sensitization phase. The second phase is the immune response phase, where on a re-exposure, these mast cells attached IgE molecules readily recognizes the allergen, and then the mast cells gets activated. When the IgE molecules recognizes the allergen, it gets activated and it releases its mediators. So that's why it's always important to ask a prior exposure to a same allergen before concluding this is an acute urticaria reaction. So this is the mast cell. So these are the, quite a bit of immunology, but the most important thing is in type 1 hypersensitivity reaction, mast cells, in most of the cases, are the cell involved in producing the allergic reaction. The cytokines involved are histamine and other chemokines and proteases. So what happens is when allergen is recognized by the Ig molecule bound to the mast cells, it releases its mediators. And the effect is you will develop inflammation. When there is an inflammation, there are characteristics of inflammation. It will increase the vascular permeability, there will be vasodilation, endothelial cell activates, and then it leads to accumulation of secondary inflammatory cells like neutrophils and so on. So this is the basis of developing an acute urticaria reaction. So this is true for anaphylaxis, this is true for acute drug reactions, and so on. The important concept here is this process occurs usually within 1 hour. It can be up to 4 hours also. So let's talk about the different types of allergic diseases. So these are the common ones that you will encounter as a primary care physician. I'm talking about the acute allergic reactions. Food allergy is quite prevalent now. So in Sri Lanka, we see quite a lot of, in children, we see quite a lot of coconut allergy, cow's milk allergy, egg allergy. And this is the other thing that we seems to encounter quite frequently in Sri Lanka. So this is called a condition called alpha-gal syndrome. Patients get bitten by a lone star tick, and after some time, after about weeks to months, whenever they consume mammalian-derived products, they seem to develop an acute a reaction, not very acute. You can see it can be delayed up to 8 hours. We have seen in our population, we have patients who have developed reactions even after 8 hours. So that's very important because sometimes you might not consider a food that eaten a previous day night uh, for development of a reaction on the next day morning. So this condition called alpha-gal syndrome, whenever they eat beef, pork, mutton, sometimes curd, milk-based products, gelatin, they develop prominent gastrointestinal symptoms and sometimes develop skin symptoms. And sometimes they might come to you only with GI symptoms. And you might treat them for a acute gastrointestinal condition. But always consider, keep this in your mind. Especially, we have seen a lot of patients coming from down south. For example, Goal Matra Hambantota, sometimes Nigambu, Chilau, Anuradhapura, Polonnaruwa, Mahiyangane. Those are especially the dry zones. We have seen quite a lot of patients presenting with this condition. So if you are a practicing doctor in this area, keep this condition in your mind because it might be helpful in differentiating certain patients when you see them in your practice. So for a fact, so now we in Sri Lanka, currently Sri Lanka has the most number of patients with alpha-gal syndrome, and we have recently published in one of the leading journals. So it's very important and it's quite relevant local condition, and it's a very new disease for the world. There are a few patients in Australia and few patients in USA. Apart from that, people very rarely see patients with this condition, but we seem to get quite a lot of patients. And also it's important to understand patients with alpha-gal syndrome have sometimes will develop certain drug allergies, for example, for cephalosporins. Because I said um, they they get sensitized themselves to gelatin also, and some of our medicines contains gelatin. So whenever they consume a drug with gelatin base, they may develop reactions. So it's important to understand this condition. So the common allergic condition is the is eczema. So I have to check. Right. Eczema is a common allergic condition, but we often uh, do not think of getting an allergy specialist opinion whenever, usually it's been followed by the dermatologist, but it's very important to understand there's a significant allergy contribution for the persistence of eczema as well as eczema. More than 50% of the asthma cases are due to allergic reactions, not due to infections. So it's very important to get the allergens sorted uh, for long-term management of your patients. Allergic rhinitis almost all patients with allergic rhinitis should be referred to allergy specialist for proper allergy assessment, because these are 100% curable conditions, not treatable. This can be permanently cured. Although it's not a true allergic disease, chronic urticaria constitute the most number of patients that would be referred or seen by you, referred to us, as well as seen by you in your practice. So it's very, very important to understand how to manage chronic urticaria. So I'll be dealing this part in one of the follow-up lectures with you guys, because I believe that this is something that as general practitioners, you should be thorough with managing, at least managing them, because I have seen these patients are being managed with multiple doses of steroids, prednisolone, and which leading to quite a lot of undesirable side effects. Because managing chronic urticaria, there are very defined clinical pathways and algorithms. So if you follow them, it's very easy to get a good control of symptoms without prescribing antihistamines. So there are less common conditions like venom allergy, especially in Sigiri area. We often see uh, some of the visitors, the tourists get bitten by bee stings and so on. Drug allergy, if you are working in the hospital, you may encounter quite a lot of drug allergies. The other thing that you need to understand is exercise-induced anaphylaxis. Again, seems to be getting quite prevalent in Sri Lanka. We see quite a lot of newspaper reports, certain individuals suddenly getting anaphylactic attacks while they are dancing in a wedding or sometimes in a party, because they might have consumed some alcohol and they take certain food items which might trigger a more severe allergic reaction. So these are cofactor dependent allergies. For example, wheat is one of the known food products that will lead to exercise-induced anaphylaxis. The same person can eat wheat without any problem, but if he eat wheat and then engage in an activity, if he engage in a strenuous activity, that coupling the exercise and wheat can trigger a reaction. It can be a life-threatening reaction. So that's very important. When you take your histories, always ask if you encounter a patient with anaphylaxis, and they will come and say, what did you eat? Doctor, mama may saman normal food tamai kave. And then you will ask, and what did you eat? Bread. Yes. Then what did you do? So I was walking and I was doing some gardening, and suddenly I started scratching my body. And then they will attribute but actually it's not the plant that produced that triggered the anaphylaxis. It was the wheat and exercise together triggered the anaphylaxis, not the plant. So it's the patients will misinterpret, and doctors usually take their word. It's always important to inquire their diet, what they did, whether they consumed alcohol. Sometimes now here in this case, the cofactor was exercise. Sometimes the cofactor can be a painkiller. NSAID, it can be a cofactor to trigger an anaphylaxis. Sometimes alcohol can be a cofactor to trigger an anaphylaxis. Sometimes certain viral infections can trigger an anaphylactic episode. And also sometimes the oral contraceptive pills, hormonal pills can also trigger an anaphylaxis in certain situations. So it's very important to get a detailed history if you encounter a patient with unusual anaphylaxis. So these are mixed diseases, not very commonly seen in primary care, but again, eosinophilic esophagitis is a condition that it's important to remember, because some patients you might see, they might come to you with repeated episodes of dyspeptic symptoms, and you treat with, well, let's say, all sorts of PPIs, but patients are not getting better. So you always need to think of, okay, if the patient is not getting cured with my PPI treatment, course of PPI treatment, I might be dealing with a case of allergy. So it's always good to get allergy referral, and we might need gastroenterologist also in our management. So those are important things as a primary care physician, because once you get the MCGP, you are more specialized primary care physicians. You should be managing them properly rather than a person who only has an MBBS degree. So when we talk about allergic diseases, I mentioned about this all previously also. We have food allergies, asthma, rhinitis, conjunctivitis, certain GI diseases and eczema. And apart from that, we have the other isolated allergies, venom allergy, drug and latex allergy. So these are, for example, you can see a person can have multiple diseases. For example, these are, we call them pattern recognition. A patient with asthma can, about more than 40 to 50% can have coexisting rhinitis as well as eczema. In children, we see rhinitis, asthma, and eczema goes together. Sometimes the patient might come and say, when I treat my skin condition, I started developing asthma. That's not the case, because these are three different diseases, but there is a common etiology. So when they treat, that will not trigger the other disease, because the trigger is the same, but they only focus on one aspect of the disease. So as a primary care physician, whenever you have a patient with different types of these diseases, always get the allergy opinion at some point in your management, because it's always important to understand the allergies and get them sorted, because that will help the patient, and also that will ease your burden also, because otherwise they will give up you, because the patient will come for asthma 3 4 times, and they will go to another doctor, because your treatment is not working, because the patient is getting the same symptoms over and over again, and somebody would say, and there is another doctor who would be treating them probably with steroids, and if you go to him, you will get a quick cure like that. So we have seen such occurrences. So it's always good to get comprehensive allergy assessment when you encounter such a patient. So allergens also, and it's, as I mentioned earlier, it's investigating and identifying all offending allergens is important to provide the best patient care. More than 80% of the allergy patients are allergic to more than one allergen. So it's very important in long-term management. Right. So I'm going to introduce this concept called allergy march. So allergy march is a concept that was brought forward because allergies evolves over time in relation to age. For example, a child who is more prone for allergic diseases the very first symptom they would express would be an eczema. The same child over the years will develop food allergies, and then asthmas, and then end up with allergic rhinitis. So that's what is called allergic march. So depending on the age, the symptom they experience could be different. But if you identify the child at the initial phase, you can prevent this child going on the allergic march. You can actually cure them, and they will have a normal life when they reach the adulthood. Don't tell your patient by the age of 12 they will get a natural cure. Yes, some of them will get a natural cure, but majority they won't get a cure. They will end up with long-term allergic rhinitis or asthma, which is, I would say, a very troublesome symptom for a school-going child, for a child who is preparing for exams, because their educational performance is significantly affected due to the symptoms of allergic rhinitis in asthma. So as a primary care provider, detect them at the earliest possible stage and help them to cure their illness rather than to letting them to live with the symptoms. So it's important for a primary care physician. So these are the 8 big foods that will trigger food allergies. So even though it's not common in Sri Lanka, then peanuts and tree nuts, we seems to be experiencing quite a few, at least over the past 10 years. Milk and egg is quite prevalent, and wheat is prevalent. Shellfish, again, a prevalent food allergy. In Sri Lankan setting, we see quite a lot of allergies to uh, coconut and some of the indigenous plants like sarana. Sarana is known to cause quite a lot of allergies among our patients. And when all keep that in your mind, and we have seen patients developing allergic reaction to jambu, durian, and it's those are quite prevalent dish allergenic foods in our local culture, apart from the big 8, which has been described all over the world. So, so I think I already talked about the importance of food allergy is because we have a significant disease burden, and it will be more because people talk about an allergy epidemic, and over the next 10 to 15 years, especially in Sri Lanka, we will have significant problem with patients who will experience allergic symptoms, right? So now this is another concept that I am going to introduce. So I was talking about the IgE mediated immediate type symptoms, but there is a condition called non-IgE reaction. There is no life-threatening reaction. The only reaction they would demonstrate is worsening of the eczema or significant GI problems. There are no blood tests. There are no other investigations that we can do to identify such people. The only way that we can do and recognize them is go for an exclusion diet. For example, you might see a child who get an exacerbation of eczema whenever there is exacerbation of eczema. And on further questioning, you may find out that whenever the child eats eggs, the exacerbation is more. And then you can ask the mother to go for 100% exclusion diet on that particular food. So if you exclude egg, you need to exclude cakes and all the products which are made out of eggs. That's how you go for 100% exclusion diet. So if sometimes I have seen, if you can find out properly, you go for a exclusion diet, sometimes within 2 to 3 weeks, the eczema completely settles. So remember, the exclusion has to happen for 1 month, not 24 hours to 48 hours, because 9-Ig reaction takes time to develop. So you are trying to reverse an 9-Ig reaction. So if you are implementing a exclusion diet, it has to happen for at least 1 month for you to recognize a change in the disease pathophysiology. So that's what I wanted to highlight in this slide. So, and the other thing, this is one of your key roles. So you need to help to prevent the unnecessary exclusion of foods that are safe and that should be eaten as part of a normal healthy diet. Because whenever we have seen whenever the patient develops an allergic reaction, acute urticaria related to food, it's the norm is don't eat protein-based products. Don't eat fish, don't eat chicken, don't eat beef, don't eat mutton, and so on. And you make, especially a child, you make that child's life really miserable. You ask the parents to go on a vegetarian diet, and then the child is not getting adequate nutrition. And sometimes because of the fear, patients, parents might continue that for years and years. I have seen patients with significant malnutrition because of the exclusion diet. So I'm just trying to highlight few. I'm not finding fault with any of these diagnoses, but look at here. This is a child who had uh, cow's milk allergy. You can see on discharge, avoid coconut. This is sorry, coconut milk allergy. This is very clear and simple that they have given the advice to avoid coconut milk for the baby. Then this is this is an unnecessary instruction. Avoid balamalu and any other allergenic food. So now I saw this mother. This mother is avoiding all protein-based products, and it's quite unfortunate. The mother is not having any illnesses, but because the child developed allergy to coconut milk, at on discharge, these unnecessary instructions were given. And this is another discharge ticket. You can see that restrict protein diet for 1 week. And this person had a chronic urticaria, not even an acute urticaria. So this person goes on a diet with restricted protein or no protein, and their lives are miserable. So because we have made their lives miserable. So if you don't give blanket restrictions, advices on blanket restrictions for foods. Allergies are not always due to food, and you need to understand which foods can cross-react with each other. For example, there are food allergy cross-reactivity charts that you can easily refer in internet. So this is one of the commonest chart that I use in my practice. So, and the other thing that we have seen is in the primary care, the goat milk and cow's milk story. Especially we have seen children who develops repeated episodes of asthma attacks. A common myth in our culture is if you give goat's milk, they will get a cure. Absolutely not, because cow's milk and goat's milk has a 92% homology. Their protein base is more or less similar uh, in these two formulas. So don't advise if the patient is allergic to cow's milk, don't advise on goat milk. So like that, if you're allergic to shellfish, you need to exclude only those types, crabs and lobster only. But they can continue with the other fish. So there are cross-reactivity charts that you can refer. So there are common associations. For example, if you're allergic to cow's milk protein, you may develop allergies to soy, and it could be as high as 10%. If you have if you're allergic to egg, there's a high chance that they will develop nut allergy. If you're allergic to cashew, you will be allergic to pistachio, like that. So this chart is quite helpful, and it's easily accessible in Google. And this is a very well recognized chart to be used in primary care also. So one of the important thing that I am highlighting for a primary care physician, because you are the primary care doctors or the doctors who will have the continuity of care of this patient. You will see a same patient over the years from birth to death. So you know the patient better than the specialist. So whenever you have a patient with persistent eczema, persistent unresolved GI symptoms, get the allergist opinion, get the allergist tested, then you can help your patients to better manage their clinical symptoms. Otherwise, you will lose the patient. So I don't think I need to spend time much on describing different types of signs and symptoms of allergies. So you may have skin reactions, respiratory symptom, GI symptoms, cardiovascular symptoms, and also neurological symptoms. Right. So allergy-focused clinical history, I thought I would touch a bit on this because it's important to understand. Always record when you take a history. Ask for the history of atopic diseases in the family because it's important, especially in asthmas, rhinitis, and eczemas. And sometimes you might hear that mother will come and say, "This child doesn't like milk." From the childhood, she has refused, or she or he has refused cow's milk. The food refusal can be one of the manifestations of a possible allergy. For example, there is a condition called oral allergy syndrome, which I will be introducing at the last as one of the last slide on today's lecture. Whenever they consume that food, they will get funny feeling, tingling feeling in the mouth and the throat, and they don't like it because they can, as a child, when you are too young, or when you are an infant, you cannot express yourself. The only way that they would express themselves are refusing the food, and then parents stop giving that, and that could be one of the reasons that they refuse food. It could be a symptom of allergy. So that's important when you take the history. And this is very important in differentiating a chronic urticaria, especially if you see a patient who comes to you with repeated attacks of allergic symptoms with hives, itching episodes. Take a detailed history. When they develop ask when they develop the symptoms first, and the speed of onset of symptoms, and try to understand whether it's associated with foods, the duration of symptoms, severity, and so on. So uh, the reproducibility is very important question that you need to ask, whether your patient has symptoms every time when they consume that food. So that's a very important question that you need to ask. If the patient does not develop symptoms on each and every exposure, that's the allergy is not related to that particular food. That's very, very clear. And also sometimes it's always important to ask the quantity they eat. So one of the best example is, we see quite a lot of prawn, shrimp, or crab allergy, because especially in Sri Lanka, they have coexisting allergy to house dust mite. So when the primary allergy is house dust mite. In house dust mite, there is a protein called tropomycin. The same protein is there in certain shellfish. So when you eat a large amount of shellfish, you tend to develop a reaction. But when they eat about couple of prawns, or one or two prawns, they don't develop. But when they eat a large amount, they will develop a reaction. So sometimes you might encounter such patients as well in your practice. So keep that in your mind. So this is not a primary allergy, but a secondary allergy or a cross-reactive allergy with house dust mite. And that happens even with different preparation. For example, the child will develop allergies to raw egg, but when they eat baked egg, they don't develop. So that's quite common with eggs as well as milk. When they're in the baked form, because of because the proteins are denatured, they don't develop allergies. But later, but if they eat raw, they will develop allergies. So that's again an important concept that you need to document in your histories, right? So I talked about the pattern recognition, and it's very important as a primary care physician. Recognize the pattern, get the allergy assessment done. It's very, very important, right? Um, so I think I already talked about the elimination and reintroduction of the foods, and so on. So basically, uh, the key take-home message here is, if you suspect a non-IgE reaction, eliminate a food and ask whether there are resolution of the whether the patient observe any resolution of symptoms after a period of elimination, and then whether the symptoms recur after reintroduction. That's an important way of recognizing your patient. Examination, there is no much of a detailed examination, but if the patient is having, especially you need to look for malnutrition and other comorbidities conditions I've been talking throughout my lecture. Blood tests, very simple. Don't do blood tests unnecessarily. The gold standard of detecting allergy, especially food allergy, is a skin prick test. So get your patients, if you suspect a true food allergy, refer to allergy specialist. Get your patients assessed properly rather than doing a comprehensive allergy panel. It's very, very important. So for diagnosis, you need a skin prick test, and also in certain cases, you can ask for a specific allergy and a specific IgE levels. And the third way of diagnosing is the FCT is food challenge test. You directly challenge, because the initial allergy workup says it's unlikely that this particular food is responsible for the symptoms. So then we will decide, go for a direct food challenges. That's the gold standard method of diagnosing food allergy, but always has to be very careful because you need to do a proper allergy assessment before challenging a patient. So skin prick testing, you need a training, but it's the cornerstone in the diagnosis of allergic diseases. And it's an excellent tool in inhaler and food allergies, and sometimes in drug allergies also. So this, so this is one of the prescriptions that I've seen, food allergy test. So this is what the lab personnel receives. This is the prescription and what they prefer. So this is quite common. This is a useless test. Don't do this test. This is only a qualitative assessment. So you can see this person, if you go by, if you try to interpret this report, this person is allergic to almost all foods on earth. So basically, they cannot eat rice. This person cannot eat wheat, any plant-based products, any meat-based products, they cannot eat. So this is a useless test. Don't order this test, because as a physician, attending physician, you can't do anything. Sometimes, the hospital will say, we are doing it because the doctors order it. So I always say, look, take the example of an HbA1c test, HbA1c test. If you want to do HbA1c, you have to always do with HPLC method, not a qualitative method. So qualitative testing is not recommended. Similarly, in allergies, don't do this allergy panel testing. Panel testing will not help you in managing the patients, and it will complicate things, because patient starts believing, oh my God, I'm allergic to everything on earth. So how can I live like that? So it's very difficult to convince a patient if you perform this type of a test. So it's very important. Don't do a panel testing. Always go for specific IgEs to particular, depend based on your clinical history. And so I talked about the food challenges. It's the diagnostic gold standard test for food allergy, and we do it in our clinics. So we exclude the other possibilities. Sometimes certain, for example, we do desensitizations. Children with milk allergies, they tend to outgrow their milk allergy, over years, and we sometimes we speed up the recovery process by desensitizing, and in these instances we challenge them with different types of foods. So this is a double-blind placebo-controlled food challenges, which is considered as the gold standard of managing food allergies. So these are similarly produced foods. Mm, we ask the patient to eat, and in one of these preparations, the patient there is the allergen is containing, the other one the allergen is not there. So based depending on that, especially in research settings, when we conduct research work, we do this for our work. So remember, challenging food challenge is challenge is the diagnostic gold standard for food allergy, but always has to happen in a specialist setting. So this is one of the other important presentations in primary care practice: recurrent rhinitis, repeated presentations with rhinitis symptoms. So I'm not going to talk about how to diagnose, but the important thing is, the key message here is, allergic rhinitis is a symptomatic IgE-driven inflammation in the nasal mucosa. It's an allergic disease. Usually these patients are being managed by the ENT surgeons, chest physicians, sometimes pediatricians, and physicians. But it's always very important to get the allergy assessment done, because this is a condition that can be treated and cured. And especially a child who is experiencing these symptoms, they will end up with quite a lot of significant complications. So this is one of the common, we say allergic salute. Whenever they have a symptom, they tend to do this. They always carry a handkerchief. So sometimes you might see a transverse crease on the nasal bridge. So that's called the nasal crease. So this is quite common. If you get into a bus, sometimes you might see patients will carry a handkerchief, do it, always doing the salute. So you need to help these patients properly identify the allergens which produces these symptoms, go for immunotherapy, and cure your patients. So that's very, very important. The commonest responsible allergen for these type of patients are house dust mite, and sometimes storage mites, and sometimes the cats and dog dengue, and uh, sometimes it can be cockroach, but not one in isolation, but sometimes the patient might be having 2 or 3 sensitivities, but that's fine. We can desensitize altogether if necessary. And we'll, in our clinics, we do proper investigations, proper allergy testing, specific IgE testing, and then decide who would benefit from desensitization. And it's very important for the patient to get a complete cure. The take-home message here is, clinical history suggestive rhinitis symptoms, get the patient tested for responsible air allergens, and then the other management depends on whether it's positive or negative. So the important message for you is, get this done from all your patients who experience rhinitis symptoms. Again, allergic conjunctivitis, again, associated with rhinitis, we see especially quite a lot in school-going children, and their education is affected due to allergic conjunctivitis. Whenever you see a patient with allergic conjunctivitis, get the allergy assessment done, get the skin prick testing done on these patients. Treatment, it's very simple. As a general practitioner or primary care physician, always aim for your aim should be reducing the inflammation to improve the quality of life. And if your patient is not responding to that, immunotherapy, aiming at inducing a tolerance. So this is Immunotherapy will cure your patient. Pharmacotherapy will relieve the symptoms and improve the quality of life. So you need to go for a combination of treatment for these patients on a long-term basis. So one of the take-home message that I'm going to give you today is never ever prescribe clofeniramine for your patients who are experiencing rhinitis symptoms, because majority of these patients are pediatric and they go to school. In literature, it says at least there'll be a 15% of impaired educational performance due to the symptoms as well as due to the first generation antihistamines. There are newer antihistamines like cetirizine, loratadine, fexofenadine, and so on. You can use any of these antihistamines, but don't use clofeniramine, Piriton, because you will ruin the child's education. Because see, those days in about 20 years ago, this is the preferred drug, but not anymore. But still, as general practitioners, sometimes as parents, we still rely on Piriton when we have more newer uh, medicines with less side effects. So always go for second generation antihistamine when you are treating such patients, because you are the ones who will be seeing them frequently. You are the one who will be treating them on a long-term basis. So it's very important. This is one of the take-home message that I wanted to give you when you are managing your patients. Intranasal steroids is very effective in controlling the symptoms and long. Now, if you want to give a better quality of life, intranasal corticosteroids are quite safe. Use it in your patients to get a better symptom control. And when you're doing so, always get the allergy opinion and get the allergen sorted. And sometimes the patients can get a complete cure. So if you talk about immunotherapy, we do have two different types of immunotherapy, sublingual and subcutaneous. We don't practice subcutaneous because it's quite, the sublingual is the latest one and you don't need injections. And now the most of these patients are pediatric population and they don't like injections. So sublingual immunotherapy, we can initiate in our specialist clinical setting, and then the patients can continue with the general practitioner. And I have a couple of general GPs I refer, I manage with them, because initiation happens from our end, and then the continuation of treatment and care happens with the primary care physician. So it will be you, and it's very important. You guys are empowered with the latest literature and the knowledge on managing allergies. So that's I think about it on the allergic rhinitis. And always you need to understand that non-allergic rhinitis also is quite common. It's about 50% in patients who have chronic rhinitis. So that's why it's important to understand whether this allergy is due to allergy, whether this rhinitis is due to allergy, or whether it's a non-allergic rhinitis. So I mentioned a few, mentioned about the oral allergy syndrome, and it's quite common in our population. That's an IG-mediated food allergy disorder. This is a mild reaction and restricted only to the oral mucosa. And it's quite prevalent in our setting. So that's why people tend to avoid certain foods when they consume, because sometimes they might say, when I eat tomato, I develop allergies. When I eat certain types of bananas, I develop allergies. So that's because of the oral allergy syndrome. They attribute it to certain foods. But so this happens when they are in raw form, but when they are in cooked form, these proteins denatured and they don't develop any symptoms. So I think it's 10:30. I think that's what I wanted to talk about today. And so I will be continuing my talk, and I'll be more focusing on more severe forms of allergies and how to manage as a primary care physician. And then I'll be talking about a bit on chronic urticarias. I think it's very important for a primary care physician to understand how to manage chronic urticaria. Yes. Mm. So there's a question that what is that syndrome? That's called alpha-gal syndrome. So I'll say alpha-gal syndrome. So any questions? Because I was asked to do more immunology lectures. So I thought because get quite a lot of referrals from you guys, and I thought I would do a more practical lecture. So that will help your practice rather than focusing on cytokines, T cells, B cells, and so on. So I think this would be more beneficial for specialist GPs like you guys, and I like general practitioners because I still have my own GP practice also. I'm still practicing it. I enjoy doing that. So, and I don't know whether you are aware of our new development. So recently our in our university we have established the Institute of Allergology and Immunology, and we'll be introducing a certificate course for GPs. And I think it will be mostly an online with some practicals on site. So I encourage you all to participate in such courses, because immunotherapy is coming up and we need you guys to manage these patients, because now you can see if we have 10% population who will need immunotherapy, we can't manage. It's we need general practitioners help in managing these patients. So we will probably need a specialized GPs who would be able to manage or follow up these patients on a long-term basis. We will definitely keep you on posted these certificate courses. And how to refer patients, we do, the University of Sri Jagadhanapura, we do have allergy clinic on every Tuesday. So we do you can refer patients, and every patient who would refer will be back referred with a initial back referral would be, we will keep you updated on the progress, and there'll be another detailed back referral on how to manage on a long-term basis, because we don't want to keep these patients, because these are chronic patients who will need long-term care, and we always want the GP to handle it on a longer term basis. We will only do we will sort out the puzzle and refer back all these patients to you all. Of course, I will share the PowerPoint presentation. So I will share with, I don't know, I have a email address. So I will share with them. Any other questions? I think in the absence of questions, we can conclude. It's already 10:30. Sure, everyone would be sleepy. So tomorrow I'll be talking about more severe forms of allergy. Would be quite interesting. And we'll talk about quite a lot of practical stuff with you. And then we will fix another day to discuss chronic urticaria and management. I think it's very, very important to understand how to manage chronic urticaria patients, because those are the ones who would be coming to you on a repeat, on a regular basis. Right. Thank you very much. I'll leave the session. Good night to you all.